volume seems a little low. Let me turn that up. All right, excellent. So things are definitely winding down in this section. We don't have a ton of stuff to go over today, but the stuff we do have to cover today is definitely important. We need to continue our fun with vocabulary by discussing the rest of our joint material in lecture today. Then we have the rest of our group presentations for the lower limb. And then, like I said, we should have time for a question and answer review for the exam on Monday. Again, I don't know how much more bigger I can make my font, but I want to remind you that your 30-point skeletal review graded for correctness is due Friday by 8 a.m. So again, use the information from today to complete that accurately, get that done. And as soon as you get that done, submit it. All right, so hopefully you've already got most of it completed. Today will help with finishing of that and turn it in. I know it's not a normal time that we meet, but that is a hard deadline. If you turn it in at 8:03 on Friday, it is late, and late assignments are accepted. That's the good news. But remember, late assignments are half credit. So right off the top, that's 15 points shaved off from that. So again, I don't like having assignments due when we're not meeting in class because it is too easy to forget that. No, not my birthday. My birthday is many things, but not a national holiday. But again, so please, please, please make sure that you're paying attention to the time. Get it as soon as you get it done, submit it. Don't wait to the last minute to submit it. And make sure you get that done. Also, remember when the assignment is due at 8 o'clock, that also is when the key will post as well. So that will give you an opportunity to check your answers. Obviously, even though it's graded for correctness, I'm not going to have it graded and back to you before the exam. But anything worth 30 points and graded for correctness is something that definitely will be emphasized on the exam, both lab and lecture. So it is going to be important to make sure that you look at it to make sure that you've gotten the material correct. Know what you got right, know what you got wrong. And then that way also, if you have any questions about it, you can ask those questions via email or whatever before the exam. All righty. Any questions on that? And then, of course, Monday, the 19th, we have our lab and lecture exam. Same format. You've taken 2 of these now. You know what to expect. You know how to be successful on that. All right. Questions on any of that? All right. Excellent. My stunned silence is beautiful. Excellent. All right. So we left off and we were working our way through our joint classifications and 2 different types, structural and functional. As we mentioned, functional classifications involve how much movement they allow. And how many functional classifications are there? 3, exactly. So when you see that question on the exam, when I'm pointing at a joint and saying, what is the functional classification of this joint? You know there's only 3 possible right answers, all right? A synarthrosis, and how much movement does that allow again?
None.
None.
Excellent. An amphiarthrosis, how much movement does that allow again?
Limited or
some.
Very little, but limited, exactly. And then our diarthroses.
Limited.
Free
freely.
But remember, we also said they're free moving, but they can be limited on the axes. And that's one of the things we're going to talk about today. Remember, the other classification for our joints are our structural classifications. Those we basically, whether there's a cavity or not present, but also the type of connective tissue that holds them together. We have a synostosis, which you will not call a bony joint, but some other people call a bony joint, which helps you to know what type of connective tissue holds the bones together with a synostosis. Bone connective tissue, excellent. Fibrous joint. All right, what kind of connective tissue holds fibrous joints together?
Fibrous connective tissue.
A fibrous connective tissue. And how many specific types of fibrous joints are there? 3, excellent. There are 3. That's going to small. No, it's not. All right, 3 specific types of fibrous joints. Excellent. What type of connective tissue holds cartilaginous joints together?
Cartilage.
Cartilage. And how many specific types of those were there?
There were like 5, 4, 7, 2.
2. Yep, for the cartilaginous, there are 2. Excellent. And then we left off with synovial. Synovial is the one we really haven't had a chance to talk about, although we did mention how many specific types. How many specific types of synovial were there again?
6.
6. Excellent. Perfect. So we will talk about those today. And so that's our goal. We haven't talked about diarthroses. We haven't talked about synovial joints. And there's a reason for that, because as we mentioned, all diarthroses are synovial joints. All synovial joints are diarthritic in the movement that they allow. So that is what we need to talk about next. That is where we left off from last class and where we're going to pick up from today. So here we have an example of a typical synovial joint. Now, synovial joints, with there being 6 types, and as we mentioned, with those 6 specific types, the shapes of them are going to be dynamically different. But there are 4 key characteristics, or 4 main characteristics. That all synovial joints maintain. Right? Remember, synovial joints are our free moving joints. That means the joints in all of my fingers. It also means our biggest, which is probably our hip, and also our smallest. Remember those auditory ossicles that are found inside the ear? What were the name of those 3 bones found inside the ear again?
Hammer,
Malleus is one of them. Excellent. Incus and what's the third? Stapes. Excellent. Remember those tiny ones? They fit on the tip of your finger, right on that one picture that we saw of them. Those 3 joints also form synovial joints with each other as well. So from those tiny the bones inside of your ear to something as big as your hip, those are all synovial joints. And all of them have the same 4 characteristics that we see in this simple illustration right here. The first characteristic is our friend articular cartilage. That is a term we've talked about before when we were discussing our, I don't want to use that, let's use blue. When we were discussing our long bones, at the end of the long bones, we have that articular cartilage. What type of tissue is the articular cartilage again?
dense, irregular connective tissue.
Well, it's a cartilage, so...
The hyaline cartilage.
Hyaline cartilage. And someone remind me again what the function of this articular cartilage was? What does articular cartilage do for the bones?
Help movement, support.
Okay, how? You're absolutely correct, but be more specific. How?
Reduce friction.
Excellent. One of the things that it does is it reduces friction. Anything else?
Provide.
Prevents tears.
Yeah, protects the ends of the bones. Absolutely. Excellent. So it reduces the friction and it protects the ends of the bones. So we have that hyaline cartilage where the bones are coming together to form their joint. All right, so that is step 1. That is the articular cartilage. One component that all synovial joints have. Next, all synovial joints have, as we mentioned, a joint cavity. This joint cavity, again, synovial joints are the only joints with joint cavities. And what is the point of having this joint cavity? What's the point of having a cavity?
Synovial fluid.
Yeah, it's going to contain a substance inside of it. Absolutely. It's going to contain a substance inside of it. Now, to make this joint cavity, and that substance, as you mentioned, it is going to contain our synovial fluid. I like that. I will put that there. So then the question becomes, how is it that we make the joint cavity? And as you look at this illustration, we're able to form a cavity around this joint because there is a joint capsule. This joint capsule is basically made of 2 layers of material, or I put it that way, that surround the joint. Oops, didn't mean to do that. That's all right. If you look closely at this illustration, you can see this joint capsule, or of course, what is also called the articular capsule. That is an acceptable term as well. Because again, articulation just means joint. There are 2 components of it. The first one there, the one we see, the outer one, the whitish one, is what is known as the fibrous capsule. That fibrous capsule is comprised of a dense fibrous connective tissue. And its job is to provide structure and integrity to the joint. It helps to maintain the joint and give it structure, make it sound. However, deep to that, and here we see it, they've highlighted it in green, lining the inner surface of that articular capsule is our synovial membrane. Oops. Excellent. And the good news is we learned about synovial membranes in the last part of the class, so you can remind me that like all membranes, it is comprised of an epithelial tissue sitting on top of a connective tissue. But if I remember correctly, our synovial membranes were a little bit wonky, a little bit interesting, right? Did it have a true epithelial tissue lining the surface of it?
No.
No, remember, it just had clusters of epithelial cells. So we kind of just refer to them as a scant layer of epithelial cells. And even the connective tissue was a little odd as well and a little unusual as well. What type of connective tissue is underlying to this?
Areolar connective.
Excellent. Areolar connective tissue. But remember, it had more fibers in it, so it had a more extensive matrix to it, giving it, again, more structure, more integrity to that synovial membrane. And as we talked about, and is the 4th component of our synovial joint, that synovial membrane produces synovial fluid. What is the function of the synovial fluid?
Lubrication.
Okay, so how so?
What?
So what does it do?
Lubrication. Provide lubrication to
Okay,
the
excellent.
movements.
Right, lubrication to help to, again, maintain the integrity of the joint, right? It helps to cushion the joint, providing that protection in there as well. But remember also, it provided something else, because if we wanted to protect this joint, if we just wanted to lubricate it, we could fill this joint with adipose tissue, for instance. And that would provide cushion and that would make it slippery. But instead, what happens is that synovial fluid is constantly being produced and then constantly being reabsorbed. There's a circulation of it in there. So why is that? Why are we constantly making and circulating that synovial fluid and then reabsorbing it again? What was the other thing that we said it did?
Provides oxygen and nutrients. To the cartilage.
Bingo. It maintains the cartilage. It provides oxygen and nutrients. It helps to remove waste from that cartilage. Excellent. As we'll talk about at the end of class today, one of the problems with getting old is the amount of synovial fluid we produce in our joints decreases. Right? And so as you have less synovial fluid in there, you have less lubrication, less cushioning, more impact, more potential damage to the hyaline cartilage, less oxygen, less nutrients. And as that cartilage gets damaged, it stops protecting the bone. The bone can become damaged. The joint becomes more creaky. It becomes more painful. It can lock up, right? Many of those problems we associate with, getting older and the loss of flexibility and movement of our joints has to do with that decrease in lubrication. Excellent. So there you go. There are the 4 characteristics that all synovial joints maintain. Prevent, no. But are there ways to improve it? Yes. One of the things we'll talk about in here, let me put my list back up here. So we have our articular cartilage, articular capsule, our joint cavity, the synovial fluid. So while overall the amount of synovial fluid we produce in a joint changes as we age, it gets less. The amount of synovial fluid that is produced in a joint is dynamic. And the 2 main factors that influence synovial fluid production are temperature and movement, right? The warmer the joint is, the more synovial fluid it is going to produce. The more you move it, the more synovial fluid that you produce. So if both my daughter and I are getting ready to go out and run for 5 miles, right, she can basically be laying on the couch, eating her Cheetos, jump up, and she is ready to go, right? If I'm going to run 5 miles, I need to stretch for a good half an hour, moving those joints, right, warming them up, getting that synovial fluid in there so that they're lubricated properly so that I don't do as much damage when I'm running as much as she does. Right, she can bounce up and run around without any problems at all. So yeah, so there are ways, stretching, doing those types of things, exercise, warming them, are all things that can increase the amount of synovial fluid you produce. All right, or just don't get old. That's the other choice. All right, questions on that? Okay, so emphasize, these are the 4 things that every single synovial joint, from the ones inside your ear all the way to your hip and shoulder, the biggest joints in the body, have to have. All synovial joints have to have these things. All right, but there are some accessory structures that some synovial joints will have. Our synovial joints are incredibly complex. Some of them can be incredibly complex, and there can be additional accessory structures. These are not required, but many joints contain 1 or more of these accessory types of structures. Here we have a joint right here. What joint are we looking at here?
The shoulder.
Shoulder.
Excellent. Remind me again, what are the bones and bone features that form the shoulder joint?
Clavicle and scapula.
Okay, so we've got the humerus and the scapula. Excellent. Those are the bones. Head of the humerus. And what was the bone feature of the scapula?
The
Well,
Acromion.
you know what I always say, if all else fails, cheat, right? We could look at the picture, we could actually see the bone feature.
Cavity.
I'm sorry?
glenoid cavity.
Glenoid cavity.
Cavity, excellent. Glenoid cavity is right there, excellent. Notice we can see in white here the articular cartilage that is over the head of the humerus and over the glenoid cavity. So the glenoid cavity of the scapula, the head of the humerus form the shoulder joint. Excellent. However, as I mentioned here, you can see some accessory structures. One of those accessory structures can be additional ligaments and tendons. Remind me again the difference between a ligament and a tendon. What does a ligament do again?
Bone to bone.
Circle.
Yeah.
Oh, yeah.
It connects bone to bone. How is that different from a tendon?
Muscles.
There
Connect.
you go. Connects muscles to bone. Excellent. Perfect. So Here, for instance, we see that the tendon of the bicep brachia helps to stabilize the shoulder joint as it comes across, and actually notice attaches to that roughened bump above the glenoid cavity. Anybody remember, because it's going to be on this exam, what that particular roughened bone feature above the glenoid cavity is?
Is that the subscapula? Shoot.
Oh, I like that mnemonic, Laura. That's good. Tender muscle for tendon. What is that bump above the head of the glenoid cavity that is an attachment point for
supraspinous spinosum or supras
getting closer? Supra definitely is above, so it is the
suprascapular
Coracoid process?
no.
supras
Supraglenoid tubercle. Right? Tubercle is an attachment point for a muscle. This one's above the glenoid cavity, supraglenoid tubercle. Right? And now we see why you're learning that stupid little bone feature, because it's the attachment point for the long head of the bicep brachia. Now, again, you don't need to know that function for this test, but if I pointed to this on a bone, do you need to know what it is? Yes, absolutely. All right, but so the supraglenoid tubercle wasn't the point. The point was that we have additional ligaments and tendons. Oh, I didn't want to erase that. So let's just cheat and do this, that, and that, and that. Ligaments and tendons that can stabilize the joints. Many of them, like this tendon, is located outside of the joint. However, there can actually be some ligaments that are actually inside the joint cavity, attach the bones this way. Now, our shoulder, thankfully, doesn't have one of those, which is why we have such tremendous range of motion, but our hip does. Our knee does. So many of our, not many, but several of our weight-bearing joints will actually have tendons that can be found actually inside the joint cavity. So they can be outside the joint cavity or actually inside the joint cavity. Speaking of inside the joint cavity, the articular capsule, that fibrous connective tissue with the synovial membrane inside of it, has the ability to basically bulge out, forming a fluid-filled pillow-like structure known as the bursa. That bursa is an extension of the articular capsule, and as such, it is lined with synovial membrane and can produce synovial fluid. And these can produce these fluid-like pillows that help to provide additional cushion. Notice, and again, normally it's nice when we're in the classroom and we have George there, our full articulated skeleton that we get a chance to play with. We could see, but again, you can imagine this. If you think about it, if we were to take our humerus and extend it out laterally, and we'll talk about what type of movement that is a little bit later, as you extend it out laterally, if you think about it, it could come up and bump against the acromion. And that would be a bad thing. We wouldn't want the neck of our humerus constantly bouncing against the bone, the acromion of the scapula. Both could get damaged that way. So luckily, we have this fluid-filled sac known as a bursa that fills that space. The patella has a bursa that helps to stabilize it, and so on and so forth. However, as we know, as we talked about before, these synovial membranes can become irritated from injury or other infection or things along those lines. And when they become irritated, they overproduce synovial fluid, and the synovial fluid in this pocket could swell. And if that were to occur, what would we call that condition?
Bursitis.
Bursitis, absolutely. In this case, a bursitis of this subacromial bursa can actually start to push your humerus down in your in the joint of your shoulder, and could also limit your range of motion, where you're not able to elevate the arm or anything like that as a result of it. So we have these bursas that can provide protection. These bursas can also elongate, and as they elongate, they typically do so to surround a tendon. When that occurs, they form what we call a tendon sheath. We talked about this a little bit in the last class. as we were talking about the bones of the carpals, right? Those carpal bones, remember we talked about because of the pisiform, because of the hamate, there's a little indentation in there. And that indentation is where many of the ligaments and many of the tendons that go to the hand are located. And there is a tendon sheath that wraps around them, stabilizing those tendons, but also the blood vessels and also the nerves. However, if you do a lot of repetitive activities with your hand, those tendons can become inflamed. And as they become inflamed, they start to squeeze inside of that tendon sheath. And as they enlarge in the tendon sheath, it squeezes the nerves, it squeezes the blood vessels, and you can get a decrease in sensitivity or pain and a tingling sensation, weakness in the hand. And what did we call that condition again?
Carpal tunnel.
Carpal tunnel syndrome, absolutely. In some cases with chronic carpal tunnel, one of the things that they will actually do is they will go in and cut that tendon sheath. It is a relatively extreme type of surgery, so it isn't something that is done frequently. But when they do it for those extreme, chronic situations, it can, in some cases, have instantaneous relief, because by releasing that tight tube around the tendons, suddenly the blood vessels and the nerves can breathe, and the pain and the tingling sensation, the weakness can go away. All right, questions on that? All right, we've moved to a different knee now. A different joint now, in this case, the knee. And here in the knee, one of the things that we see is some additional cartilage that can be placed inside of the joint. Hold on, there's a question. The tunnel is the tendon sheath. The tendon sheath is a circular tunnel that the tendons go through that sits in the carpal region. So that tendon sheath forms a tunnel that all the tendons pass through. So that's why it's called carpal tunnel, because it is a narrowing of that tunnel because of inflammation. All right. So we know that, and again, I'll do this with the highlighter. We know there is hyaline cartilage that lines the surfaces of the bone of a joint. But some joints will have additional cartilage within this joint, providing additional protection. This additional cartilage is actually fibrocartilage. And remember, fibrocartilage is the one that resists compression. So it acts as a shock absorber, like in our vertebral column, as in our vertebral discs. And so these types of additional chunks of fibrocartilage inside of a joint is what we call a meniscus. Meniscus being the singular, menisci being the plural. And we have two of these menisci inside of our knee. As I mentioned, there are many elaborate joints in our body. I'm only going to hold you responsible for the anatomy of one of those, and that is, the knee. I have already posted the handout of the material that you're responsible for the knee, and this morning I actually posted some pictures of some knee models that we'll go over a little bit later. We're going to save the knee model anatomy for after the group presentations, because we need to know the bones and bone features of the leg before we can do the knee model, but we will do that. No, typically the fibrocartilage is just in the same specific joints in the individual. So everybody has meniscus in the knee. Like I said, there's going to be some in the hip. There's some in other areas as well, but it doesn't vary the same way that, for instance, like our sesamoid bones do. Fibrocartilage may not be the only thing that provides additional cushion and protection in the joint. Here also in the knee, we see an example of a fat pad. Fat pad is just what it sounds like, gesundheit, just like what it sounds like, where you've got an additional chunk of adipose tissue that is going to provide additional cushion. In this case, notice it is inferior to the patella, so that the patella isn't constantly beating against the surface of the tibia as you flex and extend your knee. All right. So like I said, all of these structures are things that may be in synovial joints. They're not required in a synovial joint. but many synovial joints have one or more of these. All right, questions on that? All right, excellent. As I mentioned, the knee is going to be the one specialized joint I am going to hold you responsible for on this exam. You have a list of the anatomy that you're responsible for. I guarantee it will be on the lab exam. But like I said, I want to talk about the bones and bone features of the leg first before we talk about all of the specialized structures. So we'll save that for after our group presentations today. All righty, questions on that? All right, excellent. That brings us then to the 6 specific types of synovial joints. Again, remember, as we talked about, all of our synovial joints are diarthritic, meaning that they have a free range of motion, but that free range of motion may be limited by the axis. And of course, the type of motion that these joints allow is going to be determined by the shape of them. As you look here at the illustrations of both the real joints and the simplified illustrations of what they look like, you can see different types of joints allow different types of motion. So let's talk about these 6 types of joints, but we also have to talk about the types of movements that they allow. So this is, like I said, a great lead into what we're going to be talking about. This will work. A great lead into what we're going to be talking about in the muscular system. When we get to the muscular system and you learn your muscles, one of the things that you are going to be responsible for is being able to identify all of the actions of the muscles using the correct terms. So you can't say that it raises the arm or raises the shoulder, right, or lowers this or lowers that. We need to make sure we're using correct anatomical terminology. And so that starts with the types of motions that are going to be allowed, right? The way your book, and here, let's actually do it this way. Make myself bigger. The way that your book does a nice job of describing it is by the relationship of a pencil on a piece of paper, right? And so we can kind of do the same type of thing here. We get a look at this and see how this is going to work, right? Our relationship is between, in this case, my highlighter and the book. Now notice one of the ways I can move this is by just sliding it back and forth along the surface of the book. Notice it's gliding back and forth in this type of motion, but the angle between the book and the pen never changes. That type of motion is what we call a non-axial or a gliding motion. All right. So that is our first type of possible motion that can occur at a synovial joint. We can have a non-axial or a gliding, or a gliding motion. The second type of motion is an angular. If we have non-angular, then it makes sense we have an angular. And an angular motion is one where the angle between the highlighter and the book changes. Now, right now, what is the angle between the highlighter and the book? Come on, some of you must be math wizards out there.
90 degrees.
Yeah, it's 90 degrees. Excellent. So notice if I anchor the base of the marker, I can start to tilt it in relation to the book. Right now it's closer to 40 degrees. Now it's closer to 30 degrees. I can come back the other way, making it like 110 degrees. So notice in this way, I am making an angular motion. However, notice that angular motion that I made was only along one axis, just left and right. So that would be a uniaxial motion. If instead I could go left and right, and I could also go forward and backwards, right? That would be a biaxial motion, where you're moving in 2 axes. And if I could go left and right, I could go forward and back, and I could do a bunch of angles in between.
Multi-axial.
Exactly, that would be multi-axial motion. All right, so those are the axial motions. The third type of motion is a rotational motion. A rotational motion is when my highlighter rotates along its longitudinal axis. Notice this is non-axial. We're not changing the angle between the book. Oh, almost died. Between the book and the highlighter, we are just rotating it along its longitudinal axis. All right, and so that is a rotation. And then there can be special types of motions as well. For this one, I'm going to cheat and I'm going to use my finger because it's going to be easier to show you. Notice in this joint between my fingers, I'll do this one, between my proximal phalanx 2 and my second metacarpal, I have a biaxial joint. I can move my finger forward and back. I can move my finger left and right. Right, so I have that biaxial motion. When you have biaxial motion, what you're able to do is you're actually able to make those motions in an order where instead of just down and left or up, back and forth, I can add a circular motion to it. So I can go to the right and then down and to the left and up. When you make that, notice what happens is you form kind of this cone-shaped motion where the base stays the same and the distal part rotates in a circle. This type of motion is what we call a circumduction. So notice if we go back to the lecture, we can see these things that we're talking about. First, our non-axial gliding motion, where the pencil moves back and forth across the page without changing the angle. We have our angular motion, where again, if it's in one axis, it's uniaxial. If it's two, like they show here with the pencil, that would be biaxial. And if it could go to multiples in between, it would be multiaxial. Here, notice, as long as you have biaxial motion, you can then do that circumduction, where you get that form-shaped motion occurring and with that anchored base, and a rotation is that movement along the longitudinal axis, where again, it's non-axial. This one is also non-axial. That's what I want. Right? It's not changing the angle of the pencil to the paper. Instead, it is rotating it around. All right. So when we identify all 6 of our specific types of synovial joints, we are going to need to know what of these types of motions it is going to allow. All right. Questions on that? Excellent. Let's work our way through our synovial joints then.
So one of the questions about the circumduction
Yes.
joint. And circumduction joints, can we say that they are biaxial and also multiaxial?
Correct. So actually, I would say that the other way. When we talk about a joint that is either biaxial or multiaxial, biaxial or multiaxial joints are going to allow for circumduction. Okay, so circumduction is a type of movement, but you must have at least a biaxial or multiaxial joint to be able to do circumduction. All right. Great question. Any others? All right, so let's look at our 6 specific types of synovial joints. We are going to identify what the shape of the articulating surfaces looks like. And let's write this down to make sure we know it. So obviously we need to know the name of the specific types. We need to know the shape of the articulating surfaces. We need to know the type of motion it allows. And we need to know 1 or 2 examples for each type. So for our 6 types of synovial, specific types of synovial joints, those are the 4 pieces of information we need to know. We need to know what their name is, what the shape of their articulating surface is, what type of motion they allow, and be able to identify 1 or 2 examples of each. So let's do that. So obviously, like I said, the articulating surfaces for these 6 types vary, and that variation determines the movement they allow. Here is the first of our 6 specific types. It is what is known as a planar joint. A planar joint is where we have flat surfaces that are adjacent to each other. So again, notice here we have this pretty illustration that shows these 2 flat block-like surfaces that sit against each other, right? So what you have are these 2 flat surfaces, and these 2 flat surfaces can glide over the surface of each other. Notice we're not changing the angle. We're not tilting them up or tilting it back or tilting it, anything like that. The 2 flat surfaces stay against each other and just glide across each other. And so, of course, that is that gliding non-axial movement that is allowed there. So we have flat surfaces that allow a gliding motion. And the example, as we see here, are the carpal bones. Now, again, remember, this is where we get in a little bit of trouble because too often we think of the carpal bones as being the wrist. And when I think of the wrist and I hold my hand up, I see, well, my wrist lets me move my hand forward and back. My wrist lets me move my hand side to side. So this must be a biaxial type of joint. But remember, what we think of as the wrist is not truly the carpal bones. It is the relationship between the ulna and the radius and the scaphoid and the lunate. So the way you can see the actions of these intercarpal joints is actually by grabbing your wrist. If you grab and stabilize your wrist, notice you can still kind of waggle your hand back and forth. That ability to waggle the hand back and forth is because those flat carpal bones are sliding against each other in that fashion. So this is not the intercarpal joint, right? This is the intercarpal joint when I stabilize my wrist, and those are those flat gliding surfaces of the carpal bones moving against each other. And if the block-shaped carpal bones do this, then not surprisingly, the block-shaped tarsal bones do this as well. Again, if this was my foot, we wouldn't be talking about moving it up and down. We'd be talking about the ability to rotate your foot inward and outward. And that is that gliding motion. All right. Questions on that? All right, excellent. So let's talk about the most common type of synovial joint. Let's be specific. So the most common specific type of synovial joint is a hinge joint. As you can see from the illustration, with a hinge joint, you have a convex surface, an outer curved surface, that sits in a concave surface.
There's a socket and ball.
Well, be careful. We want to be careful about ball and socket because ball and socket is going to be one of those specific types. Now, notice, I think the classic example of this is, as we saw before, we saw when we were looking at the arm, we have this kind of bow tie or hourglass shaped bone feature. What was that one again? What was that hourglass bone shape, or you could even say pulley shaped bone feature of the humerus? Right, somebody presented it. Someone should know, at least one person should know. What date was the test? 19th. Let's see. 1, 2, 5 days from today.
Trochlea?
Trochlea. Excellent. And this nice concave indented bone feature of the ulna. What was that?
Olecranon.
Nope.
No?
The indentation. What does the trochlea sit in?
ulnar notch.
Nope.
The trochlea notch.
Trochlear notch. There you go. Excellent. The trochlea of the humerus sits in the trochlear notch of the ulna. A convex surface sits in a concave surface. And when it does that, as you can see here from the illustration, this is going to allow for uniaxial motion. So here in my elbow, right, I can go back and forth with my elbow, but can I get my arm to come out here to the side like this? No, if my arm comes out here to the side like this, I need to go see a doctor immediately, right? So I can't get it to rotate out that way. This just moves around one axis. And there are lots of joints that do that, right? As we talked about, the joints between the phalanges are uniaxial hinge joints. Do your feet kick out to the side from your knees? Again, hopefully not. If they do, see a doctor immediately. So there are tons of examples of this in the body. The ankle joint, the knee joint, the elbow, the phalanges, all of these are examples of uniaxial hinge joints, allowing uniaxial motion.
Question, when we're giving the example of if we were to say the humerus and the ulna for an example, or do you want a name for that joint?
So again, if I asked you for an example of a hinge, saying the elbow would be fine. But it also depends on the question, I guess. I guess technically if I asked you to identify the joint and the bones and bone features that make it, then you could say the elbow, which in this case is formed by the hinge joint of the elbow, which in this case is the trochlea of the humerus and the trochlear notch of the ulna. But if I just asked for an example of a hinge joint, saying the elbow would be fine. Okay. Great question. Any others? Alrighty. So this idea of a convex surface sitting in a concave surface is a common one. And here it's straight on, but what can happen is instead of just a circular convex and concave structure, it can be more oval in shape. So you have this oval shape convex surface and a oval shape concave surface. And remember, as we talked about, that smooth oval shaped term, the generic term for that was a condyle. So these are called condyloid joints, or because if you think about it, a flattened circle is known as an ellipse. So it's also known as an ellipsoidal joint. Either of those are appropriate names for this. The key to this type of joint is that because of the elongation of the joint surface, it is going to be able to allow biaxial motion. Again, notice the illustration, as we've talked about with my finger. The interphalangeal joints, the joint between the distal and the middle phalanges, right, allows just for uniaxial motion. But that joint between the second proximal phalanx and the second metacarpal allows for, right, biaxial motion. Right? We all took advantage of that sitting in the back seat of the car as we were sitting next to our sister, telling them, I'm not touching you, doing that circumduction of the finger using that biaxial joint. The wrist, the true wrist, right? Scaphoid, lunate, radius, ulna, right? Allows for biaxial motion. So these are examples of condyloid type joints, elongated joint cavities that allow for that biaxial motion. So all of the proximal phalanges 2 through 5 and the metacarpals 2 through 5, those are examples. But like I said, the wrist is another nice example of this as well. But notice what digit is missing from that, the first digit. And that's because the first digit has something special. The first digit has a type of condyloid-ish. So notice we started with convex concave. Then we elongated that convex and concave. Then we elongate it and bend it over itself. Again, as you can see, the illustration of this is quite elaborate. I'm not even going to try to draw it. But basically, we have an elongated convex surface that is bent down and an elongated concave surface that is bent around. And it is this very specialized joint called the saddle joint. Notice this saddle joint is located right here between the trapezium and the first metacarpal. And I believe the group that was presenting this talked about this. What's special about this saddle joint, it allows biaxial motion. I can go forward and back, I can go up and down. But what's special about it is it allows us to oppose our thumb. That ability to oppose the thumb is that ability to move your thumb across so that it is capable of touching the tips of your other fingers. Right? Back in ancient times, and I mean by back when I was in high school, when you would be driving your car and got pulled over by the police, they would do a sobriety test. And one of the things that you had to do in the sobriety test is you had to be able to go A, B, C, D, D, C, B, A, A, B, C, D, D, C, B, A, B, C, D, D, C, B, A. And so you would sit at the bar drinking, practicing that to make sure that you could get home. A, B, C, D, D, C, B, A, B, C, D, D, C, B, A, right? And so you would practice that, get that done, and then you were able to get home from the bar. Excellent. So that saddle joint, that ability to move the thumb across, that opposition, is what has truly made us the masters of the universe, right? Because that opposable thumb allows us to do what very important thing?
Grab.
Yeah, I guess that's important, but that's not the most important thing. What's the most important thing that it lets us do? Yeah, grabbing tools is important and all of that. But if we've learned anything over the last 4 years, the most important thing in the world is to be able to tweet. As long as you can tweet, you can rule the universe, right? And so that ability to oppose the thumb allows us to tweet, and that is why we are able to rule the world, right? As we've talked about before, we don't have the biggest brains, right? Not even close, right? Blue whales have the biggest brains. But when we look at those blue whales, they're way, way bigger too. So we thought, well, okay, we'll cheat and say that it's not overall brain size, but relative brain size, right? Whoever's got the biggest brain in relation to the body. And where do we fall on that category? Anybody know? Do we have the biggest brains in relation to the size of our body? Close, Allison. We actually get the silver. We don't get the gold medal. Anybody know who gets the gold medal? Who has the biggest brain in relation to the size of their bodies?
Dolphins?
Dolphins, absolutely. Dolphins have a bigger brain related to their body of us. 3/4 of the planet is covered in water. So why don't dolphins rule the world? No opposable thumb.
No thumbs.
No thumbs. Don't have a thumb, you don't get to rule the world. Exactly. A dolphin can't tweet, and because it can't tweet, it can't rule the world. All right, so there you go. Very highly specialized joint in the thumb, which has allowed us to rule the world. Someone is being asked for a meeting passcode. I'll tell you what, we're getting close to taking our first break. So ask me this question, I need more clarification of what's going on. Yeah, well, I read the book, Hitchhiker's Guide to the Galaxy. Excellent. All right, perfect. So that is our thumb. We've talked about that. There are a couple other specialized joints as well. This one is called a pivot. Now, this one is a little bit of a cheat when you look at the illustration. A pivot is basically where we have a round structure that sits inside of a cavity or a pocket, right? A peg in a socket type of activity. So there's our socket, and inside of that, we have our round peg that sits inside of there. However, if you actually look at the bones and bone features that it is showing for this, what is this bone feature? There What's this bone feature right here?
Head of radius.
There you go. Head of the radius. The head of the radius is indeed a nice round bone feature. Right? When you look at it from the top, it's round. That's where it gets its name, that round radius. Absolutely. What bone feature of the ulna does it sit in?
Notch, the radial notch.
Excellent. It sits in the radial notch of the ulna. And as we know, that radial notch is just an indentation. So it isn't quite a peg in the socket. However, the illustration also shows you how we fix this. Basically, what happens is we have a ligament. Oops, no, hold on, I wanted this to be blue. We have a ligament that will wrap around the head and anchor it in place, giving us that peg in a socket type appearance. If you think about it, we saw something similar in the cervical region. We have a nice oval shape atlas bone that sits on top of the axis, and that axis has that nice round pointed dens that sticks up. And once again, we will take a ligament and attach that ligament around the dens and put them in place. And what this allows us to do with these pivot joints is produce that non-axial rotation. As we talked about, this joint between the atlas and the axis is what allows us to shake our head no, that pivot of there. At the proximal joint of the radius and the ulna, we have the ability to be able to rotate the radius. So that head of the radius rotates in relation to the ulna. It allows for a very special movement of the arm, but when we're just looking at this part, the radius rotates. Notice it doesn't go around the entire bone, it just rotates in that location. And so these are examples of these non-axial. Notice we're not changing the angle between the radius and the ulna. We're just rotating the radius next to the ulna. And that is that pivot joint. So again, the axis and atlas, the radius and ulna proximally, all of these are examples of that non-axial rotation motion done by a pivot joint. And our last joint.
Sir, you
Yeah.
Professor- Oh,
Yes. I'm sorry, go ahead.
non-axial rotation, right? And we
Correct.
have here uniaxial movement.
I'm not sure what you're talking about.
On underneath your number 5 pivot,
Yeah.
you have non-axial rotation, but it's a axial movement.
Uniaxial movement.
No, it says non-axial rotation.
But what I'm saying is in the picture, we look at the picture and the
On the
picture.
outline?
Yes.
Okay, well, so yes. I mean, again, it is a rotation in one way. So that is what I mean by a one rotation. So notice, if you think about it, you could rotate a bone like that. That would also be a rotation. But notice if you rotated it this way, you would change the angle of it. In this case, you are getting a non-axial rotation. So I don't remember what it says on the handouts. Again, remember I tinker with these things, but this is a non-axial rotation. It's a rotation in one direction, just this way as opposed to rotating this way. And it is a non-axial rotation. So feel free to scratch out whatever it says on the notes and write non-axial rotation if that makes more sense to you. All right. Did that answer the question? Plural?
Not really.
Okay, so then what? So then what's the question?
So on your screen, like on the picture and in the book,
Okay.
where you see pivot joint, and then to the right it says uniaxial movement.
Oh, okay. Here, what you're saying? Yes. So again, what it is meaning by, in this case, a uniaxial, as I mentioned. So okay, so it says it here as well. Okay, I thought you were talking about the handout is where it said it. What they mean by uniaxial in this case is that it is just one axis of rotation. Again, if I were to rotate something this way, that would be two different axes of rotation. I could rotate something like this along the longitudinal axis, or I could rotate it this way. What they're trying to emphasize is that it is just a single type of rotation. But what I want to emphasize is that you are not changing the angle of it. So it is a uniaxial, I mean, it is, in this case, the one axis is along the vertical axis. It is just rotating on the vertical axis. So that is what they mean by a uniaxial movement. It just has one axis of movement. What I am trying to emphasize is that I guess non-angular would probably be a better way to say that. If you prefer, we could say non-angular rotation. Rotation. Does that help to clarify it? If we said non-angular instead of non-axial? So it's a non-angular rotation where it's not rotating, not changing the angle with that rotation. Does that make sense?
I think it makes sense. I think that I'm just confused on what you want us to call it.
I want you to call it a rotation. That's what I want you to call it.
Wait, that's different.
There you go.
So if you were to ask on an exam, what kind of movement is it, would you say uniaxial or non-axial?
Here, I'll tell you what, let's do this. There. Call it a non-angular rotation. How about that? If you want to call it uniaxial movement, that would be fine, but it is a non-angular rotation. That is the key to these rotations. A rotation is, again, a rotation along the longitudinal axis. So I guess technically from physics, that is a uniaxial movement. But what I want to emphasize is that it is non-angular. So let's change the vocabulary. It is a non-angular rotation, or you can call it a uniaxial rotation would be fine. Okay. Is that satisfactory?
Thanks.
Yes.
Okay, excellent. All right. Let's talk about our last type of synovial joint, and that is a ball and socket. The ball and socket, as the name would indicate, is a big round head-like structure in a big concave socket. There are only two, the shoulder and the hip. Those are the only, again, as we talked about, that head of the humerus in the glenoid cavity of the scapula. We have not identified the bones and bone features of the hip yet, but we will do that today. And the ball and socket is the only multi-axial joint. Now, in this case, it's a multi-axial joint in that I'm able to go in one plane, a second plane, multiple planes of axis in between. But notice also, not only is this a multi-axial joint, but it also allows for rotation. This can be a little bit trickier to see. If you think of the humerus, one of the easiest ways to see this is to have your elbow flexed. Because if you have your elbow flexed, then what you're able to do is, if you watch my arm, my hand comes out along the side. Now, so notice as my hand moves out and in, if you, instead of looking at my lower arm, look at my humerus, what you can actually see is that that humerus is rotating. So it is rotating as I move the arm out, and it is rotating as I move the arm out. So notice not only is this allow for multi-axial motion, but it allows for rotation as well. And you can do the same thing with the knee as well.
So if we want to compare or differentiate between the circumduction and rotation, so can we give an example of for the rotation movements, this two joints, hip and shoulder joints?
So again, with the rotation, notice the angle of my humerus doesn't change. The location of my humerus doesn't change. It just rotates in its location. If I was doing a circumduction, my humerus would go up, would go forward, would go down, would go back. And as I did this, notice the angle of my humerus changes. So again, circumduction is an angular motion, whereas a rotation is not angular. The angle of the bone doesn't change. All right. Questions on that? All right, and this kind of goes along, I think Allison was the one who asked the question. Notice as we look around at all of the joints, as we've learned, anatomists love to name everything. And so does every single joint in the body has a name, and do you need to memorize the name of every single joint in the body? Sounds like something I would do, but no, you do not, right? You don't need to know all of the specific names of the joint. Using elbow, using knee, things like that is fine, right? So I'm fine with that. So, and again, for these synovial joints, you need to be able to identify, you know, 1 or 2 examples of each of them. I'm not going to pull some random joint out of the body somewhere and say, what is the structural classification of this? But of the ones we have identified, do you need to be able to know? Absolutely. All right, questions on that?
Will we need to be able to name all the ligaments and tendons as well for the joints?
No.
Like-
The only ligaments and tendons you are going to be responsible for are the ones associated with the knee. That is the only joint where you're going to need to know the specialized structures of that joint. And like I said, we'll do that at the end of the group presentations today after we've seen all the bones and bone features. All right. Any other questions? All right, excellent. This is a good stopping point. Let's go ahead. Oh, wait, hold on. 4th type. I don't know what the 4th type was. Oh, there you go, the saddle one. Was there a question on it, or you just wanted to see the picture? Guess you got what you needed. All right, excellent.
I have a question on this one.
Yes.
How is this really different from the hinge joint as far as like the concave and convex surfaces?
It is the way that they are kind of wrapped around each other. So it is more extreme in their angles of it. And because of that extremeness of the angle, it allows for more flexibility of movement. So notice the curves of this one are way more dramatic than the curves of this one or the curves of this one. It's just basically, it's one of these that's kind of bent over on itself that gives it a very highly specialized movement and flexibility. A lot more flexibility of movement that we don't have in other type of biaxial joints.
Okay, thank you.
Yep. All righty. Any other questions on our 6 specific types of synovial joints? All right, then we are mostly done with what we need to cover today, but we still have a little bit more we need to go. So this is a good place to take our first break, and then we will talk more about these movements that we've started to hint at right now. It is 9:10 right now, so let's take a 15-minute break, and we will come back at 9. We'll make it 9:25, 15 minutes, and we will restart the recording at that point. All right, any questions on that? All right, I will see you in 15 minutes.